All right. Thank you, Dr. Luanne Rohrbach, for joining us today. We're here to talk about current best practices in type 2 translational research. And before we get to that, though, can you tell us a little bit about yourself and what your professional background is, and maybe what your favorite thing about prevention science is?
So hello, everybody, and thank you for inviting me to talk about translational research. So my professional background, let's see, I started out as an undergraduate in psychology, was always very interested in the social sciences. And then after doing some practice work, I got my Master's of Public Health degree, and then became very interested in prevention interventions. I was lucky enough to get hired at USC, where a lot of interesting prevention interventions were being developed and tested in the field. And early in my career, I was a health educator, helped to develop some of the programs that were grant funded, and then I became very interested in evaluation of these programs. So how do we know that they're working, and what's the process by which they work? So I worked on evaluation, and then decided that I really needed further education in order to get further in that field. So I got my doctorate in health behavior research, and then became a prevention scientist who worked on all phases of prevention interventions. I still contributed to the development of the programs, and put a great emphasis on evaluating them. And I also became very interested in, okay, now that we have these effective interventions, how do we get them put into use on a wide scale? So I felt like the field of translation research really was a nice blend of my experience in the practice world, as well as my interest in prevention research. So I guess that's what I would say about the prevention science field, that I think is really the best thing about it, which is that it really does a very good job of blending theory and sort of the more basic research aspects of prevention with practice. So the theory to practice and the application aspects of prevention science, I think, are incredibly important. And I think that's what distinguishes it from other sciences. Other sciences are much more focused on generating the knowledge. And certainly every scientist has a goal of putting his or her knowledge into practice. But this field is really all about translating to practice and applying what we learn.
Great. So what I'm hearing is that you really appreciate that prevention science really spans what we would consider type 1 research and type 2 translational research. Can you describe to our students what the primary difference is between those two, or what the primary differences are between type 1 and type 2 translational research?
Yeah. Well, so, these terms came from the NIH, National Institutes on Health, and I think that the distinction between the two was really thought of as, the first phase was the bench research, the basic research that would help us to understand the problem, the condition, and help us to think about the best treatments, solutions, interventions. And then the type 2 was, okay, now that we have all of that information, how do we translate it or get it put into use on a wide scale? I think in the prevention field, the distinction is similar, but we're not a clinical field per se. So that I think of type 1 research as the epidemiology and the etiology of the problems, whatever health problem we're trying to address. And in addition to epi and etiology, the actual development of the interventions. So the methods the methods for the intervention, as well as the methods to evaluate it. I consider that all type 1 research. And then moving into trials that are proof of concept. So taking all of the information about what we think will work and doing trials to prove the concept, so efficacy trials. Then type 2 is moving more into, now we have the proof of the concept for the intervention. How do we get it put in place in the real world? So, the field, as you know, has distinguished between efficacy and effectiveness trials. So effectiveness research is taking what we have found to be effective and then implementing it under less controlled conditions in the real world with all of the sort of messiness of the real world, and then evaluating how do they work under those conditions. And then once you confirm that an intervention is rigorous enough or can be sustained when implemented in real world conditions, then how do we disseminate it widely and get it implemented widely and get it institutionalized? So then that is the type 2 piece. So I guess I think of type 1 to type 2 as following the life cycle of an intervention or a treatment or a program. And again, the type 1 is the figuring out whether the concept, doing the research to understand what needs to be done, developing the concept for the intervention, proving it's effective, and then type 2, getting it put into use in the real world.
Great, thanks. So when it comes to type 2 translational work, understanding implementation fidelity is important, and ensuring that practitioners can implement a program with fidelity. So our students are going to be learning a lot about fidelity this week, implementation fidelity, that is. Can you tell us why implementation fidelity is so important?
Well, we have a pretty strong body of research that shows that when interventions, efficacious interventions, are not implemented with fidelity, they don't work as well, or in some cases don't work at all. So, I'm a public health trained person, and I think about intervention implementation from a population perspective. If we're really going to have an impact with these efficacious interventions, we don't have that many resources to implement them as widely as we would like. Let's ensure that what we're doing is going to be effective. Otherwise, in some cases, we're wasting our resources or wasting our time. So we know it's really important to achieve impact, and I guess I would say that's the most important reason to implement interventions with fidelity.
Okay. So there might be a potential tension between the fidelity of implementation and adaptation of an efficacious intervention. And I think that many practitioners out in the field, they might want to implement an evidence-based program or practice, but they may feel that the program needs to be adapted in some way to meet the community's specific needs or to be culturally responsive. Is it ever okay to adapt an evidence-based program given the importance of implementation fidelity?
So this is an issue I've thought about a lot and written about a lot, and I agree with you. There's sort of an inherent tension between fidelity and adaptation. I think that yes, it is okay to adapt an intervention in some cases, or maybe in more than some, but I've become a proponent of this idea of guided adaptation. So I think if you sit down and look at an intervention and say, well, we really like this and it would fit with our situation, but our population is different, or whatever the reason may be why you think it needs to be adapted. I think it's really important, if possible, to get in touch with the program developers and get some guidance about how you might adapt it for the situation, and what kinds of adaptations they would consider acceptable and possible, and what kinds they think would really be disturbing sort of the core components of the intervention. So I realize in practice that calling up the program developer isn't always the easiest thing to do, or it may not be possible. But I think what I've seen in this field is prevention science is really, as we scale up interventions, we're really encouraging program developers to do two things. One is to build in as much flexibility in a program as possible, so that it's not so rigid that you have to say this certain thing, or you have to talk about this certain issue in a community that may not be applicable to that community. So I think, building in the flexibility from the start when the intervention is developed that's the goal right now with intervention development. But I think the other thing that I'm seeing is that as program developers get their interventions ready for type 2 translation, for wider dissemination, they're being encouraged by companies or whoever is distributing the intervention to write a piece about, well, if you have a community that's different than the community in which we tested this, here are some ways in which you might adapt it. So the guided adaptation directives or guidance is coming from the program developers themselves. Adaptation it's a really broad concept. It's been studied to a great extent, and I think kind of the conclusion where I see the research right now is yes, we can and we need to make adaptations often, but they need to be thoughtful and guided by research and judgments to the extent possible.
Mm-hmm. Great, thanks. So our students have learned about the SPR standards of evidence for effectiveness and scale, which you participated in writing up, and we're a big part of that team. There is clearly evidence that prevention works. However, prevention programs are rarely scaled up at the state or national level to have that public health impact. So can you describe to our students what is meant by scaling up first, and then provide your thoughts on how the field can move toward a more widespread scaling up of prevention programs?
Okay. Well, so The term scaling up, I believe, is from the marketing field. It's a marketing concept, and the idea is that you've got a successful product, a product that people want, and so why not increase its use? So I think of scaling up as dissemination and distribution of an intervention, implementation of it, and also where possible evaluating the implementation of it, and doing this on a wide scale. So scaling up it's a goal, but it's also a process, and the process is pretty complicated and a little bit messy and challenging. So yeah, I think the literature has suggested that it's been challenging for people to get evidence-based interventions implemented on a wide scale. But there's also a lot of things that are known about how to facilitate it. I think one of the things that's really important is resources. Where we see in the literature over time in prevention science, where we see some of the best efforts to scale up certain interventions, for example, in the substance abuse prevention field, they were supported by both policy at the state or federal level, policy that said, hey, we're going to implement these evidence-based approaches. We're not going to just do what we feel like doing. We're going to do things that we know are successful. So policy, along with funding, along with support, funding and resources that can support these efforts, because we know that we have to do a lot of work to move efficacious interventions into practice in the real world. So sorry, did you ask me? I'm trying to remember the original question. Did you ask me to also comment on what some of those things might be to facilitate scaling up?
Yeah, sure, that'd be great.
Okay, or maybe that's one of the other questions you're going to ask. But anyway, one of the things there's a lot of different things that program developers can do to facilitate. They can come up with a good distribution system so that people can easily access information about the interventions, and also ideally that distribution system has some kind of consultation service built in so that a prospective user can call up or email or whatever a distributor and say, hey, this is my situation. We think there's a good fit here, but we're not sure. Help us think this through. So research has shown that kind of guidance is really helpful. So providing information and widely distributing it about the intervention, and then also support for implementation. And that involves a lot of different things. In addition to figuring out if the fit is there, doing some assessments of the setting in which the intervention is going to take place to see if the organization has the capacity to implement the intervention. Some of these are fairly complex and involve some extra effort on some people's parts. So do we have the capacity? If we don't, how can we build it? And determining our readiness to implement well. And then I think a really important part of getting interventions scaled up is providing training and technical assistance for organizations that have adopted an intervention. And I and others have done quite a bit of research on the importance and of training. What kind do we need? What works best? And the research pretty consistently shows that where you provide people with pre-implementation training, so here's not just handing them the manual of the intervention, but walking them through it, explaining how it came about, how to do it, tips on implementation, and then also what's, the literature always calls technical assistance. So what is that? That's being available so that when people actually start implementing, there's somebody that they can call or get in touch with to talk to about implementation problems that may be occurring, to get some coaching from master teachers, and maybe even somebody comes out and observes them implementing and gives them some tips. So training as well as technical assistance, which may be what's referred to as passive, where somebody's just there who's available and you can contact them if need be. And in some interventions or some scale-up efforts, people do actual active technical assistance. So they call up users and say, hey, I'm ready to help you out. How are things going? Mm-hmm. So I think all of those kinds of efforts are really important to move interventions from the efficacious phase to mm-hmm. the wide use. And really, the literature in this area suggests that really, if you don't do those kinds of things, you're not going to see very wide use of interventions. There, people may find out about them, but without supports to put them into place, they're probably not. The scale up isn't going to happen.
Mm-hmm. That's great. So a lot of what you mentioned are activities that program developers and researchers can take to ensure that programs are implemented well and can be scaled up. A lot of our students will be practitioners out in communities. What role do you feel that prevention practitioners can play in the effectiveness of preventive interventions?
Well, I think practitioners play a very important role in prevention science, from the beginning stages to the scale up stage. In the interventions that I've worked on developing over the years, we always have invited practitioners to the table, even from the very beginning of where we're thinking about the conception of the intervention. Like, we're thinking this will work, or according to the theory, this will work. What about from your experience? Do you think this will work? How can we do this? So they're important in the development of the intervention phase. In terms of the scale up phase, their practitioners are very important to do the training or assist the developers with the training. And, a lot of people use a training of trainer model. And so the developer will train the practitioner, who in turn will train their colleagues. They can, in the studies that I've done, practitioners are wonderful resources as sort of a master teacher or coach. So this idea that I was talking about a few minutes ago of technical assistance, boy, if you can set that up so that somebody who's in the field and who's a colleague of the people who are implementing can be the person providing the technical assistance. They're a peer, and ideally they've been there, they've implemented the particular intervention, they know it very well, and they're a very expert source of information about it.
That's great. Well, that was the last question I had for you, Dr. Rohrbach. Thank you so much for joining us today, and I know that my students, or the students in this class, will really value this Q&A and get a lot out of it. I think that a lot of what we talked about today is really going to preview a lot of the other content that our students will be learning about in this module. So just wanted to express so much thanks for joining us.
Well, thanks again for inviting me. It's been a pleasure.
Great. All right, there we go.